You're welcome to Reproductive Health segment with Dr. AJAYI. And my name is Dr. ABAYOMI AJAYI. Last week we started a discussion on endoscopic surgery. That's what we're just going to take off from this week again. And Dr. KOLADE is here to continue the discussion. Charles, it's good to see you. How are you today?
It's nice to be here. I'm fine.
Oh, yeah. I see something that you're holding. Is that Moses Road? What is this all about?
Yes, we're going to talk about this, and hopefully our guests will know more about it later in the program.
Wonderful.
Yes.
Well, yeah, we're talking today especially about hysteroscopy. If you watched the program last week, we ended up on this hysteroscopy. So we'll just take it from there. You explained to us what hysteroscopy was, that it's looking at the cavity of the uterus, the inside of the inside lining of the uterus. I think you just take it from there. What is hysteroscopy? Hysteroscopy
is a visualization of the inner lining of the womb. Yes. So basically, that's what it is. What it is like.
Okay.
Yes.
What types of hysteroscopy can you do?
We can have what we call a diagnostic hysteroscopy, by which we are just going inside to make a decision. Someone is having irregular bleeding. Someone is having recurrent abortion. Why is that happening? So you can have a diagnostic hysteroscopy. Then you can also have what we call an operative or a surgical hysteroscopy, at which you not only make a diagnosis about what the problem is, but you also offer treatments at that same sitting. So you could have a diagnostic or an operative hysteroscopy.
Okay. Charles, before we go into why should anybody have a hysteroscopy, I think it's good to look at what you have in your hand.
Yes.
Yeah, to show people how tiny and fine this equipment we call a hysteroscopy is.
So this is what we call a 5mm hysteroscopy.
Yeah.
Yes. So simple procedure. What we do at the hysteroscopy is that we use something to open the entrance to the womb a little bit before we introduce this instrument.
Yeah.
Now this instrument, at this end, there's a magnifying lens here, and at this end is attached to a camera, so that whatever is inside the womb, I can see it on the screen.
So you don't need to do this. Like that was what we were doing so many years ago.
No, we don't need to do that anymore.
Okay.
We don't need to do that anymore. So whatever image is within the lining of the womb is projected onto a screen, and we can see and we can carefully go inside. If there's a fibroid there, we can carefully bring it out. If there's a scar tissue, or we can carefully separate it. If they stuck together, we can bring. If there's a cancer, we can bring it out. If there's any form of abnormality causing excessive bleeding, whatever, we can make a diagnosis, and more often than not, at the same sitting, we can also offer treatments. Okay,
maybe before also we go into the indications of why should anybody do it. One thing we also need to state very clearly, that when you do hysteroscopy, you only have access to the inside of the uterus. So if you have a fibroid that is not inside of the uterus, you cannot treat it through this equipment.
Exactly.
Okay. Wonderful. So can you tell us what are the things that can be done through this, your beautiful
So if someone has excessive bleeding,
yeah,
and we think it's due to a fibroid, this will help. But then, as we said, it can only help remove the fibroid that is inside the uterus, not the one that is outside, or the one that is going from the outside and projecting inside. Now, if someone has had fibroid surgery, we've seen that happens, that has had 1 fibroid surgery, 2 fibroid surgeries, and then the periods are scanty. We want to know why is this period scanty. We can make a diagnosis of why. We can also offer treatment. Someone has had a D&C, or she had an excessive bleeding during delivery and something was done, periods are scanty. A hysteroscopy can also be of benefit. Now, coming to fertility, at times, someone have a recurrent abortion, have a pregnancy, 6 weeks, I miscarry, another. So recurrent abortion, we can hysteroscopy beneficial. Then recurrent IVF failures. I see people have done 3 IVFs, no pregnancy, and nobody's thinking about the hysteroscopy. So that's not good enough. Recurrent IVF failure, we should look at the cavity of the womb to see, is there anything that is preventing implantation?
Now, what are the, maybe I'm tempted to talk a little bit more about this. You talked about after surgery, that some people don't see their menses again. Okay, because that's a common thing that we see all the time. And people usually label it Asherman syndrome, which we know is scar inside the endometrium.
Yes.
Now, what is the advantage of using hysteroscopy over the traditional dilatation and curettage, and you put a coil? What is the advantage?
Yes, the advantage is that with the hysteroscopy, you can make a specific diagnosis. Because what we do traditionally is that I just assume that the lining is stuck together, and I put an instrument inside and I scrape the lining. I've not made a proper diagnosis. Then, because the procedure I'm doing is blind, I probably be separating where it doesn't need to be separated. Yes.
And leave where it needs to be separated because you can't get to it.
Yes, and I can actually cause more harm than offer benefits. So this is more precise. It helps us make a diagnosis, and I can actually go to where the pathology is and carefully separate it with minimal risk of causing injury to the women.
And you can even plan your treatment.
Exactly.
Whether you need to do more than once.
Once, yes.
And
because some people have to do a hysteroscopy more than once, especially when there is scanty periods.
Wonderful. Are there any complications with this procedure?
Yes, like every other surgery. Yes, you can have injury to adjacent vessel, adjacent organs. We can have excessive bleeding. We can have infections. But then, like I always like to say, in good hands, proper precautions are taken. These are very minimal. These are less than 0.5%.
In good hands, almost all equipment are safe. In bad hands, all equipment are not safe. How do you prepare patients for hysteroscopy?
Okay, for hysteroscopy, we just say they should abstain from taking any solids by mouth for 6 hours. That's good enough.
Okay.
Yes.
Now, is there any need for any form of anesthesia in these patients?
Yes. And there are different types of anesthesia. For some people, if it's just diagnostic, we just want to make a diagnosis, we're not doing any surgical things, we can just give some local anesthesia around the cervix, what we call a cervical block. You know, that will just be sufficient. But some people, they may need something more than that they may have to be put to sleep. And some people say, oh, I've been put to sleep, I reacted. They could actually have what we call a spinal anesthesia, that is from the belly button below, they can't feel anything. Yes. So we have at least those 3 forms can be used to offer hysteroscopy.
Well, one question I'm sure many people want to ask is, after doing hysteroscopy, how soon can I start doing my daily chores?
About that same day, really. Because for most people, hysteroscopy takes about 15 minutes, 20 minutes. Well, maybe the effect on anesthesia will last for another 1-2 hours. But after that, you can go back home by yourself. Yes. Well, I wouldn't advise you to go back to work because you may still be a bit drowsy. But you can go back to home, and from the next day, you can go about your daily duties.
Okay. Now, this is a question I want you to think just a little bit about before you answer. Do you think we should routinely, for everybody who wants to do IVF, do endoscopy or hysteroscopy?
Hysteroscopy? I don't think so.
Okay.
I don't think so.
Why?
For the simple reason that it's a surgical procedure. It has its risks. And it's not everybody that necessarily has to be exposed to that risk. Especially when we consider that we have simpler things that can be done that are less invasive, that are not as expensive, that doesn't require that level of skill in manpower to do them. So I don't think we should routinely do a hysteroscopy. But we have simpler things to be done. If we do the simpler things to make a diagnosis of an abnormality, then we know we don't have a choice. Then we have to do a hysteroscopy to correct such abnormalities.
Oh, please. Give us a clue. What are the simpler things
simpler
that we can
things.
do?
We have something we call a saline sonohysterogram, which in actual fact is actually a scan being done. But apart from the scan being done, we also infuse some fluid into the womb so that the layers of the womb can come apart and one can see any form of abnormality in there. But this essentially is diagnostic. We can't treat complaints through this. But we can make a diagnosis and say, oh, these selected patients should go ahead and have an intervention to correct the abnormalities found.
Wonderful. Now, maybe the next 1 minute or so, can we just talk about these fibroids that are in the cavity of the uterus? Okay. For instance, how do you know whether you can just remove this once, or maybe you need to come back again in order to remove this, or this cannot even be touched?
Touched at all.
Yeah.
Well, I'll have to be a bit technical here, because generally speaking, fibroids within the cavity, they are graded 0, 1, 2. So if it's stage 0, the whole fibroid is within the cavity, and the whole fibroid could actually be removed by hysteroscopy. Now, if it is stage 1, more than 50% of the fibroid is jutting out into the cavity. And for that kind of patient, you'll need more than 1 session to remove, because when I remove the much I can remove now, I probably have to come in another 2 or 3 months and remove what is left. Now, if it's stage 2, I really can't help with the hysteroscopy. It's better done by what we call a laparoscopy or open surgery.
Thank you very much. I think why I asked this question is that because you see some patients after hysteroscopy, they come back and say, doctor, the fibroid is still there. You didn't do anything. And because you've just given us the answer, because it's not every kind of fibroid that we can remove through the. But sometimes when we're just doing IVF, we just want to make sure that the place is
as normal as possible.
Wonderful.
Before we go ahead.
So it's on this note, viewers, that we're going to end this week. I hope you have learned more about hysteroscopy today, and we'll see you next week. Thank you very much for staying tuned.